and you're good to go.
Yeah.
Okay, thank you. Thank you very much, Dr. Swati and Nikhil. That was a wonderful presentation. Now, having seen about how toric IOLs are so very good for us to go as far as toricity is concerned, there are some other methodologies that we can use in case of patients who cannot afford toric IOLs, or in cases where you feel that the astigmatism is less and you can deal with other methods. So an astigmatic eye, as we know, the cornea is steep on one axis and is flatter on the other. Astigmatism is a common refractive error which is present in as much as 13% of all refractive errors, and we know that there is a shift from with the rule to against the rule with age. Now, pre-existing astigmatism in cataract patients, as we know, is quite a number, which is about 47.4% being up to 0.75. We have 43.8% in the range of 0.75 to 2, and about 10% being more than 2 diopters. So in all, we can see there are almost about 80 to 90% of patients who have pre-existing astigmatism. So the need to correct this is it just goes without saying. So these are the various techniques that we can have. Now, OCCIs, that is opposite clear corneal incision, the basis of it is that it causes a flattening in that particular axis, which is the steeper axis, and an additional clear corneal incision in the opposite direction will enhance the flattening. This is the concept of doing an OCCI. Now, in my practice, I have seen that up to 1 diopter of flattening can be easily achieved by doing an OCCI. And for astigmatism, which is more than 1 diopter, I would go for a limbal relaxing incision. Now, this is a procedure which corrects up to 1 to 2 to 2.5 diopters of astigmatism. I would not go for LRI for anything more than 2 to 2.5. This procedure causes less glare and discomfort as compared to astigmatic keratotomies. The incision heals faster and the optical quality of the cornea is preserved. And the procedure is safer and very easy to incorporate in our routine cataract surgeries. The principles of LRI are that the cornea flattens over any incision and becomes steeper 90 degrees from the site of the incision. Now, as you can see here, this is the normal cornea, which is K1 and K2 are the same. That means there is no astigmatism. And against the rule wherein the horizontal K is greater than the vertical one. So paired LRIs are usually the norm, unless sometimes if it's very small astigmatism, you can just do your phaco incision on the steep axis up to about 0.5 to 0.75 can be corrected. But of course, you need to do know your surgically induced astigmatism for that. So this is the principle of the LRI, wherein you place your incisions on the steeper axis, and knowing that the opposite axis will have a steepening effect. Now, there are different nomograms. Very commonly used nomogram is the simpler one is the Gill's nomogram, and the other one is the Nishamin, which is also called NAPA, that is age and Pachy adjusted one, wherein you have the with the rule and with the against the rule. So if you know where your steep axis is and you know the age of the patient, you can place your incisions in that axis and you know what is the arc length of the incisions that you're going to do. Now here, the important thing is that your blade depth has to be about 90% of the thinnest pachymetry. You have now the LRI calculator online, just like you have the Barrett calculator and everything. This is on the AMO platform, the Johnson & Johnson one. You feed in the data of your patient where the steep and flat K are put in, the axis is there, and also the thinnest corneal depth, that is the pachymetry. And surgically induced astigmatism also is fed in, and then you get a result like this, where you know where your phaco incision is, whether you're sitting temporal or at the superior end, and you can also see how many degrees are you going to have of your arc length, depending upon the extent of astigmatism. Now, these are the instruments that are being used. This is the blade, which is a pre-adjusted blade, which is about 600 microns. You have the Mendy's ring, and you also have this marker for the 3, 6, and 9 o'clock positions. And this marker, the last one, which is for marking your actual axis if it is going to be in an oblique direction. Now, this is a small video. The markings are done where you can see here, it's an arc length of about 50 degrees. You make sure that the cornea is absolutely dry for this, and the blade has to be perpendicular to the cornea so that you have a uniform depth when you make your incision. And the incision that you make has to be a little within the corneal limbal blood vessels. It should not be on the blood vessels. A similar incision is then placed on the opposite side. Again, the marking has already been done. Just about 0.5 millimeters within the corneal limbus is what is ideal. Of course, sometimes you may have patients where the corneal vasculature, the limbal vasculature may be extending more than that. And in that case, if you go for the LRI, you may have more of the healing that occurs later, and the astigmatic correction may reduce over a period of time. So this is very important that you avoid the vasculature. Now, points to remember as far as LRIs are concerned are, you have to obtain a corneal topography pre-operatively. You have to take care of if any patient has any irregular cornea or a form-fresh keratoconus or a pellucid marginal degeneration. It is better to avoid LRIs. You need to mark the cornea well. An upright position, of course, as we all know about the in supine position, it is not advisable. You plan to treat the corneal astigmatism and not the lenticular astigmatism. It's purely the corneal astigmatism. And like Nikhil said, it's very important that you don't put any drops or anything when you are doing the axial length and the keratometry when you are doing your A scans. And of course, use of an appropriate nomogram. The LRI calculator is something that is very useful today. Earlier, we used to have the chart of the NAPA nomogram in our OTs and trying to see how many arc degrees and all that. Choosing a good marking system, choosing a good blade, 600 micron standard depth is advisable, 90% of the depth of the thinnest cornea, and you have to make sure that the handle of the blade is absolutely perpendicular to your cornea, so you get a uniform depth throughout the arc. The incision, like I said, should be just within the avascular cornea. You could decide whether you want to do it before or after. There are two schools of thought here. I prefer to do it after my phaco is done, because sometimes there are chances of it going through, and then you could have a problem of a wound leak and things like that. So I would rather do it later. And under corrections, always are better than overcorrections, because if you have an undercorrection, you can go ahead and tackle that later on, but an overcorrection can be a little problematic. So cornea should be absolutely dry. Always make the eyeball very tense with viscoelastic so you get a uniform cut. And viscoelastic is also facilitates a smooth incision. Now, if you compare the LRIs with the AKs, they are a little more difficult to do. They are slightly within the corneas, and that is why some of these incisions, they do not heal for a very long period of time. There are more colored halos and glare with AKs as compared to LRIs, and LRIs are definitely more easy to use. The comparison of LRI and toric IOLs, well, yes, toric IOLs do take upper edge, but in patients where the patients cannot afford it, then this could be an option. So the take-home message is up to 1 diopters OCCI, 1 to 2 diopters or 2.5 LRIs, and anything more than 2.5 go for toric IOLs. Thank you very much.
Thank you, Dr. Shilpa. That was a very beautiful presentation. And I would like to share that even for panoptics, which I did recently, I had a 0.75 SIL, and the patient did not want to go for panoptic torics, but it came out, I did an LRI and it came out absolutely spot on, a plano thing. So Dr. Shilpa, I guess you're mute.
No.
Okay, fine. So what has been your experience like all over these years?
Well, very honestly, I used to do a lot of LRIs earlier. Nowadays, of course, I avoid them. In patients who are really not able to afford, I would rather tackle the toricity with a toric IOL, with an Indian IOL or something. Another experience that I had, one of the reasons why I have reduced doing LRIs nowadays, unless it's absolutely necessary, is that patients do complain of irritation and pricking sensation for quite a period of time, especially if your arc lengths are little longer. So I am not doing it for anything more than 1 diopter nowadays.
Okay, and how long is the precaution? Like,
you need to give lubricants for at least a period of 6 weeks to 8 weeks. But the initial, what I had seen was when the arc length is more, that means when you are dealing with more astigmatism, the patients do complain of irritation. That is, they can see well, but they are very upset because of the irritation that they face. Okay. So smaller arc lengths are better. This has been my experience.
Okay. And do we have insights from Dr. Vavikar, Dr. Arup, Dr. Rajipal, sir?
I agree with her totally that nowadays LRI are restricted only for astigmatism between 0.7 and 1. Beyond that, we go for toric, or if the patient is affording, just give it up.